I want to welcome everyone to today's parallel section on purchasing policy for improving healthcare service delivery. We are going to get, I believe it will be an interesting section, very engaging, because we're going to hear from our colleagues in Tanzania, Indonesia, India, and Malawi, the experiences with respect to how to improve purchasing of services through health financing mechanisms and other things. So we want to welcome you all, and we should be starting right away. We have with us Leon, who is an MD student at Heidelberg Institute of Global Health, and he will be presenting to us facilitators and barriers to the introduction of digital solutions for strategic purchasing in health, case study of IMIS in Tanzania. Then Firdaus Hafiz, who is a lecturer at Universitas Gadjah Mada in Indonesia, will be presenting to us health financing and strategic health purchasing innovation to support TB elimination in Indonesia. And it's going to be an interesting section. Then we have Radhika Jain, who is a postdoctoral research fellow. She will be presenting to us private hospital responses to reimbursement changes under insurance in India. And last but not the least, we have Stephanie Hyung, who is presenting to us strengthening initiative to strengthen subnational implementation of UHC through innovative health financing and management structures in 2 districts in Malawi. Unfortunately, she's not with us. She's not going to be in the panel in terms of question and answer, but her colleague Ian Yoon is right on ground to take this presentation and respond to the questions. So we want to say welcome. One thing we want to advise is please make sure that you use the Q&A, live Q&A chat box to drop your questions for any of us, any of the speakers, and also the discussion platform for discussions, comments, and interaction. Thank you all and welcome. I'll now hand over to Leon to make his presentation.
Thank you all for joining. So we wanted to close the gap in implementation research on digital solutions for health financing and more specifically strategic purchasing, and looked at the software Emis, or Insurance Management Information System. It is a software developed by the Swiss Tropical and Public Health Institute that handles all insurance-related business procedures for a health insurance scheme by linking beneficiary, provider, and purchaser data. It was first implemented in Tanzania in 2012 within the framework of the Improved Community Health Funds, which is a health insurance scheme for the informal and rural sector. It has since then been developed to an open source project called Open Emis and has been implemented in various settings in various countries, promoted by the German and Swiss development cooperation agencies. Despite all these implementation efforts, there has not really been any scientific research published on Emis or any comparable software for health financing. So we looked at the claim management function in Emis. If a facility sees a CHF insured patient, they have to enter a claim into Emis in order to be reimbursed afterwards for that treatment. And we think this is a very key function of the whole software, because only if claims are properly entered into the system, the whole insurance scheme can be sustainable. So we asked ourselves, how is the Emis claim management function adopted by healthcare workers in Tanzania? And then how do healthcare workers, but also CHF management staff working with Emis, experience this implementation? To answer these questions, we developed a mixed methods design with a quantitative phase first, where for all facilities, all public first level facilities called dispensaries in Tanzania, in the 3 project regions, we compared the number of reported claims in Emis with a number of claims that we would expect under ideal circumstances for each facility and each month in 2017, followed by a qualitative phase consisting of 21 semi-structured interviews with healthcare workers and CHF management. So if we go to our quantitative results, you can see the median number of claims reported in Emis by each facility for every month in 2017. It's the blue line, and on the green line you can also see the median number of claims we would expect each facility to have entered in each month in 2017. So our first and very striking finding is quite obvious here. There is an enormous gap between the number of claims reported in Emis and the number of claims we would have expected. There was an average gap of 80% difference between reported and expected claims. Facilities just have not entered nearly as many claims as they should have. So we did a logistic regression and found that larger facilities, facilities with more insured patients in their catchment area, and facilities with a larger distance to the district headquarters where the CHF supervisor sits were even more likely to underreport. But these rather small coefficients and these few explanatory variables can most definitely not explain this enormous gap between the number of claims reported and expected throughout regions, districts, months, and almost every facility. So we went to the field and to our interviews with basically one question in mind: what is so bad about Emis? Why do people not like to use it? And again, we were a little surprised, because at first we were met with an overwhelmingly positive perception of Emis. As this CHF coordinator summarized it, so when it comes to Emis itself, Emis is perfect. We were only met with very little criticism regarding Emis as a software or various functions of Emis, and only 3 out of 21 participants would go back to a paper-based reporting system if they could do so. So the question remained, why do facility staff not enter claims into Emis? And the answer seemed to be that adverse external circumstances hindered a proper adoption of the software. In almost every single interview, high workload or low staffing levels, or a high staff turnover, meaning that staff that was trained in Emis was quickly shifted away somewhere else and no one was left who was trained in Emis, was a huge problem. As this clinical officer summarized it, of course, there is no person who is capable of working 24 hours, and working with Emis was, or still is, an additional task for healthcare staff, and many felt they did not have the time to do so. Then also the CHF had a problem with reimbursements. In most facilities and most months, the facilities just did not receive the amount of money that they should have received for the claims they sent. This clinical officer gave the example of sending 100 claims, each one being worth 5,000 shilling, but then at the end of the month just receiving 6,000 shilling in total. This, of course, is extremely demoralizing and led to not entering claims in the future anymore. Other problems mentioned were low network coverage. Although Emis has an offline component, this still posed a problem for many facilities in Tanzania. Lack of training or technological knowledge was also mentioned many times. And then in one region, we had an RBF scheme running that was just paying out way more money than the CHF did. So healthcare workers didn't really feel the need to claim anything for the CHF via Emis, because financing from RBF was just way more sufficient. Other issues mentioned were enrollment issues, lack of motivation, just of course that can always be a problem, but also hardware issues. Most facilities used phones, only very few had laptops to use Emis on, and most staff in these rural areas did not feel comfortable or competent in troubleshooting any issues that arose with the phones or the laptops. So if we want to come to a conclusion, we can break it down into maybe 3 points. The first is a very positive point. That is that Emis seems to be accepted and appreciated as a helpful tool to facilitate business procedures for health financing, and appreciated not only by CHF management staff, but also by healthcare workers. But the adoption of IT interventions for health financing, maybe even more than other interventions, depends heavily on a supporting environment and the architecture of the health system. So as a recommendation for the future, we conclude that a critical evaluation of existing infrastructure and existing resources is key for any successful future implementation, not only of Emis or Open Emis, but also for any other health financing software for that matter. Thank you very much. And if you have any questions, please feel free to reach out to me via email.
Right. Thank you so much for that. I don't know if participants have any questions for Leon. And yeah, so you can either type in the live question and answer section or chat box so that we can route the question to Leon. But in the meantime, I did take some notes, and maybe while we are waiting for the questions to come from the audience, I would like to ask Leon to make some clarifications, because you shared there's a table that speaks to the regression analysis, the results of the regression analysis. We wonder if you could explain in more details how these coefficients can be interpreted and the implications of that. Leon, please, you can unmute yourself and respond.
Yes, sure. Thank you very much for that question, Felix. I understand any confusion about the regression coefficients because it was a logistic regression where the coefficients aren't that easy to interpret. So maybe it's easier to look at it from an odds perspective. So for example, we looked at the share of people insured at the facility catchment area, and we had a coefficient of 0.071, which was highly significant. Translating this into odds ratios would mean we had an odds ratio of 1.073, still not telling you a lot, but that means that if we increase the percentage of people insured in the facility catchment area by 10%, that would mean that the odds of the facility being classified as underreporting would increase by the factor of 0.73. Or to make it even more easy to understand, if the percentage of people insured in the catchment area would increase by 14%, roughly 14%, then the odds of the facility being underreporting, so entering less claims that they should, would increase by the factor of 1, so would be twice as high. This shows that the regression analysis results weren't too strong. So these 4 factors that we found maybe can't explain underreporting in general, but they still give us an idea of where the problem was bigger than in some other places.
Thanks, Leon, for that response. So while we are waiting for questions, I think it's interesting to see that there is a huge gap between what is reported and what is expected. Now, it looks obvious that the health facilities are losing very important source of revenue. So I was wondering, during your research, or especially during the interviews, did they make comments related to that? How are they grappling with that loss of potential revenue they can use to maybe improve service delivery or attend to issues in their health facilities? Maybe, or is the government also trying to help resolve these problems? Because if the Emis was intended to help solve problems with claims, and then it's sort of some problems are arising, are there efforts being made by either the hospital managers or the policymakers to resolve this?
Yes, that's a very good question, because it seems counterintuitive to enter less claims than you have clients in your facility. And actually, when we started this research, we were more concerned about maybe fraud being a problem. So people entering more claims than we would expect. That really wasn't the case in most facilities. Yeah, what did people say about it? One main problem was mentioned in the in the presentation that the funds were just not sufficient enough. So the CHF had an elaborate scheme of how it would pay out the money to the facilities, but we found that in many places, especially in 2017, I think nowadays it is a little better, facilities just did not receive the money they should have received, or just only a tiny fraction of that. So if you imagine not receiving any or just close to any money for this additional work that you do it for 2 months, 3 months, 4 months maybe, but then you stop doing it because it's not worth anything. You don't gain anything. So that was maybe one of the main things we found why they weren't really concerned with losing money, because they didn't feel they would gain any money if they would do it anyway.
Oh, thanks, Leon. Maybe I'll still go back to the audience or the other participants. Please feel free to still type in your questions for Leon, even though we're going to move to the next presentation in a few seconds, but still feel free to drop questions or comments in the discussion. So we have a discussion box where you can throw comments and all of that, but we have a live Q&A section, chat box where you can still drop questions for Leon, and we'll come back to him later for any additional questions.
There actually are a few questions in the box, Felix.
Okay, sorry.
I don't know if you can see them as well.
Okay, I didn't. Oh, great. Okay, excellent. Now I can see. So from Francois, I hope I got your name right. It says, Radical, do you think issue is your? Oh, okay. Sorry. Okay, sorry. It's not. Okay.
I can maybe just go ahead and start with one that I see.
Start with the question. Yeah, sure.
Sure. Because Boniface, I hope I pronounced that correctly, you asked quite a few questions. Thanks for that. One of your questions was how do public and private facilities compare? We would have loved to answer that question, but due to the way that the Community Health Insurance Fund worked, which was primarily public and private facilities could opt in, but very little did, we were only left with 2 private facilities in our analysis set. So we threw them out and only analyzed public facilities. So we can't answer that, unfortunately. Should I continue with the other questions from Boniface?
Yes, please go ahead. Yes, Leon.
All right, sure. Then you asked, are the health facilities allowed to operate autonomously, and do the reimbursements go directly to health facilities? A very good question as well. That was one of the things that they changed in this improved community health fund, as opposed to an older community health fund that was implemented years ago. Every single facility, down to the dispensaries, the very first line facilities, has their own bank account. So the money that they receive, they can manage for themselves. They have, I think they should give about 70% to materials and drugs and stuff, and 30% to other improvements, but they are in general very free to work with the money the way they wanted to. But again, in many cases, the money they received was just maybe not enough to have any impact on the quality of services provided. Oh, that answers your questions. If the question is not answered properly, just ask them again. The last question by Boniface was, do participating health facilities have other sources of funds other than CHF? You ask very good questions. The basic funding, government funding, was not discontinued. So the funding through CHF is something that they should receive in addition to any funds that they had in general. But additionally to that, I mentioned in the presentation an RBF scheme in one region, so a results-based financing scheme that we found interfered a lot with the CHF and claim entering in Emis, because the RBF scheme was another additional resource for funds for the facilities, which tended to pay out a lot more money than the CHF did. So we found that especially in this region, this might have been a factor decreasing the number of claims in Emis as well, because the money that they received from the RBF was very much in comparison to the money that they could receive via claiming through Emis in the CHF. So maybe these additional sources of funding were a problem actually for the implementation of Emis itself.
All right, thanks, Leon. Just one last question.
Sure.
Fedas had asked that before, what was the information system used before the Open Emis, and do Open Emis modify the previous system or replace it or double the burden of health workers? Of course, I think the issue of reporting was highlighted in your presentation, but he was trying to ask what were the digital platform used before Open Emis for claims management?
Yeah, actually before Emis, it was a purely paper-based claiming system. And Emis was the big innovation, trying to make the whole claiming system an online claiming system. For a few years, I would say 3 years maybe, in many areas, these two systems, paper-based and online via Emis, were used parallel. Some facilities still use paper-based, some already used Emis, but nowadays it's completely or 100% Emis, which is the first digital solution for claiming in Tanzania, at least for the CHF. All
right. Okay. Thank you. Maybe we'll get back to any of the other questions, but okay, so I don't know whether we responded to this from Boniface about how if facilities are allowed to operate autonomously with respect to the reimbursements, or you go directly to the health facilities?
I tried to answer it before. Yeah, I hope that worked out.
Okay, excellent. Okay, thanks, Leon. I mean, we'll still go back to the questions if there are ones that are unannounced that we are not answered, but I think we should just move next to the next presentation. That is by Fedaus.
Hi, I'm Hafiz, and it's an honor for me to be here presenting Indonesian experience on the TB Strategic Health Purchasing exercise at the 6th Global Health Symposium on Health System Research. I will present the key activities of the process as current efforts to improve the purchasing arrangements to drive more effective service delivery, efficient provider behavior, and higher quality of TB services. As disclaimers, this work is made possible by the general support of USAID, and the contents are the responsibility of R4D. Here I start with the challenges of TB burden in Indonesia. Indonesia is ranked 3rd among the highest TB burden countries in the world, 8% of cases worldwide, ranks in the 20 highest multi-drug resistant TB burden countries in the world, 4th leading cause of death behind diabetes, stroke, and heart disease, and there were 98,000 people who died due to TB in 2018. Huge challenges with missing cases and economic burden of TB in Indonesia extremely high, loss of productivity due to premature death estimated at $6 billion. But a lot of progress has been made actually. Health system in Indonesia through the National Health Insurance, we call it JKN, provides an opportunity to improve financial protection for TB patients, coverage of over 85% of the populations, and provide access to diagnostic and treatment services for patients with TB and expected to provide financial protection to TB patients. However, TB services in primary care are paid using capitation payment, and in secondary care, JKN reimburses for TB services using bundle in a CBG payment or case-based payment. Therefore, it doesn't create effective purchasing arrangement and incentives to address two important challenges, which is increasing case finding and notifications, shifting to more cost-effective primary care services. So the aim of this activity to identify how existing purchasing arrangement, including benefit package, contracting arrangement, monitoring, and payment method lead to a negative incentives for achieving service delivery objective for TB. And based on the result, we aim to design solutions and test new purchasing arrangement to improve those incentives and make progress on TB services which is we are still doing ongoing to 2020 to 2023. We conduct three types of analysis. The first one is the quantitative method, which we analyze from the National Health Insurance data sample 2015 and 16. And then the second one, we are using qualitative method, focusing on the providers, which is public and private primary care, public and private hospital, and the district and provincial health office. The study conducted at 5 provinces: West Java, Banten, East Java, South Sulawesi, and North Sumatra. And we found a lot of interesting things. And then the third one, after we discuss it with the policymakers and stakeholders, we develop a budget impact analysis using the decision modeling from the Medan districts as the sample. Here are the results. We highlight several service delivery patterns that go against clinical guidelines that are influenced by chicken purchasing arrangement. The first one, the low treatment in primary care, especially among private providers, where more than half or 58% of their confirmed TB cases to secondary care for treatment, while public primary care centers referred 1/4 only. Almost all or 81% visits for confirmed TB that were referred to secondary were uncomplicated TB cases, which should be treated in primary care. Private primary care providers have a weak incentive to invest in treating resource-insensitive TB patients using limited capitation fund. And the second one, low donor referral from hospital to primary care for treatment. So the uncomplicated TB cases that were treated via outpatient secondary care cost 188 billion rupiah, or equal to $12 million. The JKN payment to hospital outpatient department for treatment for uncomplicated drug-sensitive TB provides strong incentive against down referral for primary care. And the third one, adherence to regulation and clinical guidelines. The majority of TB in secondary care was coded as TB without bacteriological or histological confirmation. Therefore, it's indicated there was overuse of chest X-ray under use of smear microscopy and gene expert for diagnosis TB, even though gene expert has been spread across the country. Case notification and monitoring. TB cases notification and monitoring is perceived as additional burden without adequate compensation. Therefore, private providers relied on public primary care. Case went missing in transfer between hospital and primary care. Therefore, this work has produced a clear descriptive analysis where diagnosis and treatment for TB in Indonesia, at least for those patients and service covered in national health insurance, have a delivery patterns that against clinical guidelines. Therefore, we propose policy options to influence health facilities reforming incentives. The first one, we provide a clear benefit specification where we're focusing on the TB drug sensitive from diagnostic, treatment, monitoring, and preventive. And the second one, have a better contracting arrangement with the providers to improve with the improving credentialing process from the national health insurance and contracting process, and mapping to improve the referral pathway. And the third one is to have a strong monitoring systems, have an interoperability between the national TB program and national health insurance information system, so it has less burden for the providers, and contracting TB case managers that can have an independence to monitoring the services. And the last one is to strengthening the provider payment mechanisms that are giving incentives to providers, where we propose the fee-for-service payment for TB diagnostic and episode-based payment for outpatient treatment. Of course, it's all need to be linked with the quality of services and notifications. After we develop all the policies recommendation, we develop a budget impact analysis that expected to increase the number of diagnosis TB cases and successful treatment. Of course, the cost of treatment is getting higher, on total cost getting higher with the new scenario, because we are expecting new cases. But however, we expected also to have a cost treatment success rate in the new scenario is lower than the current scenario, from $150 to $144. And the next steps for the pilot preparations, we will do the finalizing of pilot design, including the finalizing technical design, determining the scale and scope, and design the monitoring and evaluations. And the second one, the strategic communications to engage all the stakeholders, including the districts that we will involve for the piloting. And the third one, capacity building, just to make sure everyone's have a same understanding. So we will run a training and run trial interventions on the paper base. And the last one, the implementation itself, where we introduce the waiver for the change because the regulation will be very specific for the piloting site and establish pilot governance and management arrangement, with of course the phasing of the implementations. Thanks for USAID who support Ministry of Health and UGM. Thank you.
All right. Thanks, Hafiz, for that presentation. And let me just quickly check if we have questions for you already. Okay, so I mean, before then, so what I wanted to ask is, with respect to the provider payment for the TB, I know you, in your recommendation, you said maybe case-based is something that you want to recommend. So what's the current state of provider payment? What sort of platforms? And also, you also mentioned about contracting. What is the current, what is happening currently within your study setting with respect to what sort of provider payment is being used, and what are the maybe challenges or experiences doing that before recommending this one for TB?
Yeah, thank you, Felix Obi, for your questions and comments. It's quite a challenge today because the TB, there's still a lot of missing cases in TB, while we are using capitations in primary care and like a DRG in hospital level. So we call it INA CBGs. So what happens when we use capitations and primary care is not willing to treat the patients, and they prefer to refer the patient to the hospital, while in the hospital it's costs, of course, more expensive, and then they have a more incentive to keep the patients there. However, you know, the quality of the TB treatment in the hospital somehow have a low quality in this case. So that's the main problems. So that's why we are trying to find innovations of a payment mechanism for this kind of TB program. Thank you. I hope it answered.
Okay. Thanks for that. Let me check if we have any. Okay, great. So we have some questions from Kamalia. I don't know if it's a lady or a guy, but it said, have you implemented these changes in provider payment mechanisms? And if yes, what are the indicators that you would use to monitor progress, especially in quality of TB care? I guess because the treatment guidelines are not really followed and all. So maybe you can respond to that before we go to the next question.
Yeah. Thank you, Camiliano. Yeah, we haven't implemented these changes of payment mechanism. So we are still in the piloting phase. We are trying to develop the technical design first, and that's to make sure that the governments and the national health insurance can buy in our idea. So it's still under progress. I hope we can implement it this year. And regarding to the indicators that we'll use to monitor, there's a lot of indicators from the input, process, and output. Of course, the outcome, which is the TB success rate. But we also try to find how the input process, where the health facilities would like to, you know, invest for TB facilities, and then how's the process of the quality, whether they use the generic drugs or fixed drugs combinations, where the governments try to encourage, and then for the lower of missing cases, and the notification itself. I mean, that's the most important part in Indonesia, because we have a lot of missing cases and the quality of reporting itself. Yeah, I think it's really related to the presenter before, where the reporting system also still very challenging in the TB programs. Thank you.
there's a question from Paula Pavlenko. She said, did you think about introducing performance-based payment at the primary care level to target uncomplicated TB?
Yes, that's what we are trying to introduce, that we're having the episode-based payment. We will try to provide the first payment and the end of the intensive phase. I'm sorry, I cannot explain all the detail, but that's what our idea. So when they have a follow-up treatment, have a good follow-up monitorings of TB, then they will get the incentives. And also at the end of the treatments, when we get the successful rate, then they will get also the other claim instead of a claim every time they're visiting. So we are trying to introduce that things.
Okay. Yeah, so there are two other questions that are interesting. One has to do with contracting. So let me read it out. It says, can you explain how you recommend JKN contracts along the patient pathway, and particularly for initial diagnosis?
Yeah, thank you, Pierre Marie Matango. I'm sorry if I mispronounced it. Yeah, this is one of the foundation, I think, for the JKN contracts, just to make sure that the health facility have a commitment to treat TB patients along with the, the guidelines of patient pathway that they need to, for example, make sure they have an initial diagnosis using the gene expert, for example, nowadays, and then microscopic tests instead of going to X-ray directly or without anything, clinical diagnosis, which is it's really interesting that in a hospital, even though they have a high chance of getting the microscopic test, it's more than 50% are diagnosed with the non-microbial testing. So we're still wondering whether it is something that negative tests in the primary care, or this is just a different behavior in the hospital level. So that's part of the initial diagnosis also, which is very challenging to have a gene expert for across the country. Yeah, happy to hear from your lesson learned also if in your country, if it's possible also. Thank you.
All right, thanks. And there's another side that has to do with the approach to the costing. So Leon wanted to know about the cost you calculated for your model. For instance, the cost in your model appeared to be a lot higher than what is obtainable currently, and wanted to understand if this is correct assumption, and if possible, how would you convince policymakers to adopt your model because of the cost?
Yeah, it's very challenging. Thanks, Leon, for your questions. That's why we're still working on it, just to make sure the policymakers can buy in our model. So it hasn't finished yet. So based on our analysis before, that it's really interesting that there's a really few numbers of visit that we are expecting. For example, 8 visits for 6 months. We are expecting for them to visit the health facilities and get the proper treatment until they finish. But however, we only can find only visit on average like 3 times, and then not a proper diagnostic test. So it feels that they're still under treatment. So there's a lot of unmet need there. So that's why it seems that it's higher, but actually it's a really high quality, the normative one. That's why somehow we need to play with it. We show it also in the cost per successful treatment, which is lower. So that's why we try to sell that one. I know it's not convincing enough. So that's why in the next step, we will also develop how the economic burdens can be averted by having the high quality of treatments. For example, low burden of MDR-TB in the futures, and then a low of productivity loss in the futures. That's what we are still working on it. I hope it can sell, but I know sometimes it's quite hard to digest by the policymakers. Happy to hear from you also how to convince the policymakers.
Yeah, thanks for Hafiz, and that's actually interesting because I know in your implementation plan there is the place for strategic communication, so you have a lot of work to do there based on feedback from Leon. Well, just before we move on, there is a question from Boniface. He wanted to know the differences in provider payments that exist between primary care and secondary facilities? Are they using the same PPM, or is there some differences?
Yeah, as I tried to answer your questions at the beginning, so the proper payment and the primary care, we're using capitation, where there's reimbursements per beneficiaries who are registered in the health facilities. So there's capitations. They will get same amount in a month, a fixed amount in a month, and then for the secondary care is based on the visit. Using the diagnostics related group, or DRG, so a bundle payment for TB. For example, one visit they got $20, for example. So it's a fixed rate also. Yeah.
Okay, just a write up to that before we move on. Paola had actually wanted to ask if you were also considering introducing performance-based payments at the primary care level. To I think you brought that earlier, but kind of linking it to the provider payment for primary and secondary. I don't know if you want to elaborate.
Yeah, so currently there's really limited of performance-based payment in the primary care. For example, so we are looking of how many referral rate that you have done in the last month or the last quarter. So it will affect your capitation rate. However, it's, TB patient is just really a few, but it's really a priority of national program. So it's not have a big impact on the the performance space that meant to. So I think in this case we need to make sure that it's something special need to be put on the S indicators, and need to change the payment mechanism also there, so that can change the behaviors.
All right, thank you so much. And I guess we might still have more questions for you later, but I think it will be, looking at the time, it would be nice for us to go to the next presenter. That is Radhika Jain. She's going to share an interesting perspective from the private sector. I know what we have been looking at has been government, public sector experience. So it would be nice to hear from Radhika the experience from India. All right.
Hi, thanks for joining me today. I'll be talking about private hospital behavior under government health insurance in India, and this is joint work with Pascaline Dupas. There's going to be a lot more information on the slides than I can cover in 8 minutes, but bear with me. So, lower income countries, lower and middle income countries have been expanding health insurance to meet the goals of universal health coverage. And in India, these programs have been scaled up since about 2008. And most of them have very similar characteristics. They target poor households, focus on hospital care, include the private sector in delivery, entitle patients to completely free care. And the important part of these programs is they use bundled prospectively set reimbursement systems. So rather than paying the hospital a fee for every service that it decides to provide, the government pays the hospital a fixed predetermined rate for an entire patient visit or service or diagnosis. And the idea is that this cuts costs while providing financial protection to patients. The evidence on these programs to date has found that while there's some increases in utilization, there have been modest or no impact on patient health expenditures, but it's been unclear why this is the case. And so today we focus on one particular explanation, which is the role of private hospitals in these programs. We study the BSBY insurance program, which entitles poor households to completely free care at public and impaneled private hospitals for a range of services. As I mentioned, hospitals are paid at fixed rates for each service, and these rates are supposed to cover the full costs of care, so that care is entirely free. The rates are set somewhat arbitrarily not arbitrarily, but there's not systematic cost data, so they're set statewide. And all of the claims are filed through an IT system. And the program has scaled up very rapidly in the first 4 years, and I should point out that it's very similar to the national PMJ program. This is just to give you a sense of the kinds of hospitals we're talking about. They're fairly small. So we have a unique data set for this study. We use administrative claims data, which we received every 2 to 3 weeks from the government, and it includes some basic information on hospital, the services provided, and patient information, including the phone number. What we do is then we use these phone numbers to call patients and do phone surveys. So we identify a bunch of services, we sample them randomly. For those sampled patients, we call them within 3 weeks of the claim being filed and collect data on services received, out-of-pocket payments, some measures of care quality, and socioeconomic status. And so altogether, we have about 20,000 surveys over the course of a year. I think it's worth pointing out that we're focusing on patients who have a claim filed. So they're eligible, enrolled, and the hospital has filed a claim and received reimbursement for this service. The first result I'll show you is I pointed out that these programs are supposed to provide care entirely for free, but we find that across a range of services, their hospitals are charging substantial amounts of money. Almost half of all patients pay something, and the average payment is about $30, which for these households is quite a lot. Again, keep in mind that these are patients for whom the hospital has filed a claim and received reimbursement. So really isolating the fact that hospitals are charging for care that should be free. So the big question then is, why do hospitals charge? And there are two sort of broad competing explanations. One is balance billing, which is just the idea that hospitals, if the reimbursement rates are not sufficient to cover the cost of providing care, which may be the case since there is no good cost data, hospitals simply charge patients the difference between what the cost of providing care is and what the reimbursement is that they get from the government. The second explanation that is that this is entirely double billing. It's that hospitals are taking advantage that patients don't know of the fact that patients don't know about the programs and their entitlements, or that there's not very much competition, so they have a lot of power. And so they're simply charging patients whatever they want, well above the cost. And now disentangling these two explanations is extremely difficult in cross-sectional data, especially because there are no cost data available, but is really important for policy. So what we do to sort of explore this is take advantage of a policy reform that changed the reimbursement rates for hospitals for different services overnight. And the intuition is that because the costs of providing a service are not going to change overnight, all of a sudden the government is just paying the hospital more for providing something. So if the hospital was doing balance billing and charging patients for the difference between its costs and reimbursement, then when the government reimburses a hospital more, the hospital should charge an equivalent amount less to patients. And if we don't see this, then it's more supportive of the double billing explanation. And so essentially we use claims and survey data for the 6 months before and after the reform and a difference in differences analysis to study this. The first, this slide is just to show you that indeed overnight, the vertical line is the policy reform. These are different coefficients. Essentially for every 1 rupee increase in the reimbursement rate for a package, the hospital reimbursed amount increased by almost exactly 1 rupee. So the policy reform worked. This now shows the effect of the same reform on out-of-pocket charges. What you see is for every 1 rupee increase in reimbursements, out-of-pocket charges to patients decreased by about 50 paisa. So there's a large decline, but it's less than the amount of the reimbursement increase. Simply put, if you want to think about it this way, for every 100 rupees more that the government paid the hospital, hospitals charge patients 50 rupees less, which implies that the rest was captured by them as profits. We don't find evidence of how hospitals passing benefits on in other forms. And so broadly, what this shows is that some hospitals were engaging in balance billing, and which suggests that the reimbursement rates were too low, and increasing them helped and reduce the charges patients faced. But not all hospitals, since the decrease in out-of-pocket charges is incomplete, and we find some evidence that this is particularly so in less competitive markets. So broadly, the first thing I've shown is that this is, I think, the first systematic evidence of out-of-pocket charges under insurance, and it really points to the fact that simply mandating that care should be free does not ensure it. It requires oversight and enforcement. And the second set of results I've shown you is that increasing reimbursements to hospitals decreases out-of-pocket charges substantially, but not completely, and the hospitals are pocketing some of this. And really, this points to in order for these programs to be effective, policy needs to pay attention both to setting the reimbursement rate carefully and increasing hospital monitoring, particularly in areas where there aren't market pressures to discipline hospitals. And hospital monitoring or accountability can take many forms, whether that's awareness or increasing competition or doing hospital audits and monitoring. I think just closing with the broad implications of this study, I think one is that outsourcing delivery to the private sector has some benefits, but also comes with unique challenges. Second, I think, is that reimbursement rates under these programs in India are a key policy lever and are very difficult to set and require ongoing, both detailed cost data and ongoing assessment. And lastly, we've shown that, it is possible to leverage the administrative data coming out of these programs to do a lot more, to understand a lot more about how they are doing, and to supplement them with things like cheap phone surveys to understand the mechanisms of the program. Thanks very much.
All right, thank you for that interesting presentation. Yeah, it's actually interesting. So maybe before I check the questions, I wanted to ask you if, for instance, there has been any efforts to, maybe from the patient side, because patients seem to be the one at the receiving end having to pay for out of pocket for something that they shouldn't be paying for. So have there been any efforts like patient right groups or advocacy groups by CSOs to sort of engage both the private hospitals and government, the policymakers, to resolve that?
Yeah. Oh, so I just wanted to check. Can you hear me okay?
Yeah, we can see you, Radhika. Yeah.
Oh, great. Okay. Yeah. So there are existing NGOs in the state that are.
Sorry, it looks like it's muted a bit. Sorry. Can you raise maybe the volume of your microphone a bit?
Does that work? No difference?
I don't know if others can hear you. Great, I can hear you now.
You can hear me. Okay, great. So what was I saying? Oh, right. That yeah, one of the things we found in our research is that patients are not very fully aware of their entitlements under the program. And there are NGOs that are trying to sort of increase awareness of their entitlements. The government has also invested a lot in spreading information about the program and what patients are entitled to. No?
Okay.
Yeah, so that they can.
It's kind of going up and it's kind of yeah.
Yeah, this was the problem earlier too, and I'm not sure why it's doing this. I tested this yesterday. Fine. Sorry.
Okay.
So right. So I was saying, yeah. So there's lots of efforts to increase awareness. The problem, in some we actually did an experiment ourselves where we provided patients with information about their entitlement under the program. And what we found was that for specialized sort of tertiary care, especially in areas where there's only one hospital, information is important, but it's very difficult for patients to use it before the hospital. The power imbalance between the hospital and the patient is substantial. And we're talking about, especially for care where the patient is isolating care.
Can't hear you anymore.
Well, I'm not sure what to do about this, except maybe I can.
Yeah, really sorry about that. Maybe someone had also asked about what sanctions can be applied to the hospitals that charge out of pocket. Maybe because you're having some audio challenges, you can also possibly respond to the questions directly. Maybe you can type, but we'll possibly come back to you once the audio kind of improves. Would that be fine by you? Okay. Sorry about the hitches. I'm sorry about, yeah, that's technology. It's okay. So I think since we still have some time, we can go to the last presentation for this section, and then we can also come back to you for questions to respond to some of the questions that can come. So I would like to invite Stephanie to make the presentation from Malawi.
Hi, this is Stephanie Hyung. I'm together with my colleague, Dr. Gif Kuala-Zira, who is the Director of Health and Social Services in Blantyre District. Today, we'll be presenting on strengthening subnational implementation of the Essential Health Package through innovative health financing and management structures in 2 districts of Malawi. The government of Malawi has prioritized an Essential Health Package, which is a set of cost-effective health services to be delivered free at the point of care to all Malawians. The government has decentralized EHP implementation to district health management teams, and subnational health management was identified as key to operationalizing national policy commitments, such as the Essential Health Package. However, the health financing context is highly constrained, with only $36 per capita available in total health expenditures per year, compared to the WHO recommendation of $86 per capita. Efficient and coordinated resource allocation is therefore crucial to maximize EHP delivery. In this context, district health management teams face key challenges, such as inconsistent availability of critical inputs, such as drugs and staff, as well as challenges in coordinating fragmented partner resources. 77% of the health sector is financed by external partners, and there are 227 implementing partners in the health sector. As a result, there may be a mismatch between the nationally defined Essential Health Package and the services that are actually available on the ground to the population at the district and facility levels. As a result, we developed a district planning tool that was used to support district health offices in identifying management and health systems barriers to EHP delivery. There are 3 components to the tool. First of all, district health management teams conducted a qualitative assessment on EHP service availability at the facility level, as well as availability of key inputs such as health workforce. Second, the district teams conducted a bottleneck analysis that was using program performance from the DHIS2 to identify underperforming EHP interventions. This was supplemented by quantitative and qualitative assessment to identify the most relevant bottlenecks and root causes that constrain EHP delivery. These activities were costed and prioritized and ultimately incorporated into the district plans and the government budgets. Finally, districts also conducted resource mapping and partner mapping activities in order to strengthen joint planning, transparency, and accountability between the district health offices and their partners. Partners reported funding commitments disaggregated by financing source, thematic area, health facility, and implementation timeline that were then integrated into district plans. The tool is the foundation of the Ministry of Health's district planning guidelines, which is used by all 29 districts. The tool is also complemented by other management tools and processes that were organically suggested by the DHMTs and added to their routine management practices. This includes the DIP Action Tracker, as well as quarterly review templates to systematically monitor government and partner progress towards DIP implementation. These have been endorsed by the National MOH Planning Department and disseminated to all 29 districts of Malawi. In this work, we assess the short-term impacts of introducing these planning tools in 2 districts, Blantyre and Palombe, focusing on EHP availability and financing. I will pass it now to my colleague, Dr. Gif Kuala-Zira, who will present the results and conclusions.
So, key findings from the boarding analysis were that the districts are only able to present 17 out of 23 essential health package services on average, and also the fact that 60% of our health activities are actually funded by partners. And this poses a huge challenge at implementation level because it means you've got too many implementing units on the ground. And because of that, you end up with some unnecessary duplication of activities as well as wastage of resources. So the planning tool was very important to ensure that all the stakeholders in the district have got one reference point where everybody is actually able to submit the activities, and that acts as a reference point for all the stakeholders that are actually implementing activities in the district. And Blantyre managed to actually increase the number of partners whose activities actually reflected in the DIP from 5% to 45%. And also, the planning alone has managed to actually improve the district capacity to actually analyze and address the EHP interventions and bottlenecks that are actually being conducted in the district. And in conclusion, now that we have a plan, the next thing is to have a systematic review of service availability and bottlenecks to ensure that the plan that we have, this common planning tool that we have, is actually being translated into the services that are actually being provided at operation level. And also, the joint planning and coordination between district partners is critical in highly donor-funded and fragmented funding landscapes to ensure that we are all pulling in the same direction, or we're all swimming in one direction as stakeholders for health services in the district. However, we need to conduct further research in terms of tracking the process and aligning expenditure against the district plans. That is to ensure that we have got some kind of joint implementation of activities, so that we're actually able to follow that what was actually planned in the district implementation plan is what is actually being implemented on the ground. And then the other step is to ensure that there is joint monitoring to ensure that we're actually keeping track of what was actually planned in the DIP. And then fourthly, we can conduct what is called a joint evaluation to see if actually we have made any impact or difference on the ground when all is said and done. Thank you very much.
All right. Thank you for that presentation. Before we dive into the questions from participants, I'm actually curious to know what sort of donor coordination platforms that aligns with the Paris Declaration that speaks to donor coordination in country. So maybe we don't have Stephanie on ground, but Ian Yun, who is also one of the co-authors of this paper, I would like you to respond to that. Maybe give us some context about how donor coordination is happening in Malawi, because from your presentation, we have so many donor partners, and I guess it's interesting to know how the coordination is happening. I know the tool you developed, the planning tool, is helping capture the plans, but it's interesting to know what sort of governance structures and institutional frameworks are helping for donor coordination in Malawi.
Yeah, Felix, thanks for the question. So I guess firstly, with respect to the national level, when it comes to partner coordination, all partners are aligning with government policy and signing memorandums of understanding, so that at least at the national level there is a kind of framework through which funding can be coordinated either on or off budget. However, what we wanted to highlight in this piece of research was the fact that it's fine to coordinate at national level, but then when you get down to the subnational level and you still have 60% of money coming from partners, and in the case of Blantyre, there's I think almost 80 partners to coordinate. What mechanisms can you use at that level, since while they may be saying at national level, we're all aligned, when you get down to district, and you saw in that graph, 5% of partner funding is actually being reported to the district health authority. So I think we are leveraging this, I guess, partner coordination framework that is currently being used at national level and bringing it down to the district level, so that you're coming up with almost mini resource tracking exercises, accountability mechanisms, so that we're not only accountable at national level, but we're also trying to align with the district health authorities at the subnational level, especially in the context of Malawi, which is decentralizing. Felix, you might still be on mute.
Thanks, Ian. The other question I wanted to ask before I check if we have any new questions was generally about aligning the plans with the budget. What has been the experience over there?
Yeah, another great question. And I think maybe in contrast to what my colleagues have presented so far on kind of, results-based finance or output-based budgeting, Malawi is in a very different situation where almost all of our financing, budgeting, and expenditures are captured at a cost item level. So, budgets for the district health authorities are not developed with an output of EHP services in mind. They're based on the number of people in the population, the percentage split of rural versus urban, but never really thinking about what is a kind of smarter way of capturing or ensuring that the EHP as a package of services is delivered at district level. So I think what we are trying to do is optimize within a constrained system where you can't do output-based budgeting. So what is the best that you can do is to come up with very credible, very robustly costed budgets and I guess requests to the district councils, so that when it comes to ensuring that money is moving to these essential health package services, it's not currently going to be based on what services you're actually providing in post. It's always going to be the planning in pre. So I think our key focus here with the DHOs is develop the credible plan and then allow the rest to fall into place, just purely based on the context in Malawi.
All right, thanks, Ian. And I'm still checking if we have any question, but I haven't seen any. In case if you spot, you could respond. The other bit I wanted to ask is with respect to the budget process, the public finance management system in Malawi. So what is the role of the parliament in kind of ensuring that the health sector gets the budget? Of course, and are there also efforts towards having mechanisms for either pooled funding or basket funding for donor funding from the donors? Yeah. So I know there is the framework for bringing all the plans together, but the financing, whether it's pooled at some point, whether virtually or in some way, yes.
Yeah, it's a great question. And actually, historically, Malawi has played with pooling resources from the partners on budget to ensure that, all funding is moving towards government priorities. We used to have a swap, I think back in 2015, 13-15. But that has since dissolved for a wide variety of reasons. Most particularly, I think partners started to lose trust in the way in which that on-budget financing was being administered. And so I think what we are focusing on now is how do you strengthen that PFM system such that we can get back to a place of pooled finance, at least from the partner perspective, because, whilst it's nice for Malawi to have a package of essential services that are supposed to be provided free at the point of care, if all of the money is coming from, or most of the money is coming from partners, the accountability towards that package it's quite limited as long as partners remain in control of that financing, just due to competing priorities and the way that projects are developed. So I think strengthening the system through these interventions, improving financial management is the priority for the government now, so that eventually you can get back to a place where that type of donor financing or type of donor funding pooling is back on the table.
There was just one question by Boniface, he was asking about if you've been able to evaluate a whole financial year. Maybe I'm not so clear about that, but he said, have you been able to evaluate a whole financial year? Yeah, I think it's something we can respond. Yeah, go ahead if you have anything.
Yeah, sure. Our work with CHAI at least has been running for the last 2 years on this project. So we do know, kind of the results of the intervention. But I think what I really want to highlight is back to the Malawian context, which is calculating service delivery, understanding what the outputs are of the budgeting process, are just something that the system is not built to monitor, at least from the public perspective. So, really understanding which services and to what degree and at what cost are they being delivered is something that's just really not well understood by the government, purely on the merits of the PFM system. However, I do think some of the wider results that we were talking about, at least in the paper, where you're moving from 5 or 10% of partners reporting to the government at subnational level in terms of what their budgets are, what activities, what services are they providing, where they're providing these services. And we've seen significant increases, at least in the number of partners who are participating in that process. And in addition to that, I think we do see some moves towards more credibility, at least anecdotally, in the planning and budgeting process. And I think that's something that has not been well evaluated, and really, highlighted at the end of the presentation that's kind of where we're trying to go in the next phase of the work with the district health authorities.
Thanks, Ian. I know we just have 3 more minutes to wrap up. Thanks for all the speakers. I don't know if Radhika is back, in case you wanted to respond to some of the questions. Just maybe use 30 seconds to respond to any, if your audio is fine. And then I would want Leon to just quickly respond to something. Somebody had asked if the pricing in terms of the payments for claims, if there was negotiation between the health facilities and the CHF. I don't know if it's something you can quickly respond to in the next 1 minute before we wrap up.
Sure. So one of the questions was about whether, can you hear me okay?
Sure, yes,
so one of the questions,
fine.
Great. One of the questions was whether private facilities, the whole presentation was about how these reimbursement rates are set and how for many hospitals, they're not adequate to cover their costs. Private facilities some representatives of private hospitals are involved in the discussion, the negotiation of what the reimbursement rates should be. The bigger problem is that it's one set of reimbursement rates that's set for the entire state there's basically no data on costs to drive these negotiations. So it's really a matter of like sitting in a room and some private doctors, some public doctors deciding together how much should heart surgery be reimbursed for. So I'll hand it back to Leon. I think he had it.
Thanks. Leon, do you have anything to say with respect to if health facilities were involved in negotiations about what the claims in terms of the rates are?
Yeah, in this scenario for the ICHF in Tanzania, the facilities themselves weren't really involved in the negotiation of prices. They were really set more by the project team together with government partners. But again, if I read your question correctly, Denise, it wasn't really about how high the prices were. The problems were that the reimbursements weren't coming in at all.
Sure, thanks a lot. Yeah, I know, I'm sorry guys, we will have to wrap up because we have just 1 more minute. First, I want to thank everyone for participating. Thanks for all the speakers. It's been very interesting section. I know the question and answers, if we have not responded to them, I think the conversation can still continue on the platform. And we want to thank all of you. Thanks. First of all, I want to thank Leon, thank Fidelis, thanks also Radhika and Stephanie and Ian for the presentations. And I think feel free to respond to any questions that we have not responded to. Use the chat box to to answer and let the conversation continue. And thank you all for joining us, and do have a wonderful either evening wherever you are, or great afternoon. And for those who is still your morning, have a wonderful breakfast. And I think you should get some coffee, as I've had mine as well. Have a wonderful day, and thanks for joining.
Thank you.